we'll continue with it.
Okay, no
Will
problem.
you able to share your screens or like PPTs? Is it possible
Yeah,
sharing?
I'll share it. Let me see. Okay, you can
Yeah,
see.
yes. So a
Okay.
few minutes, we'll get back at in short minutes, like after
Yeah.
introductions.
Yeah, no problem.
Okay, sir.
You can hear me clearly, right?
Yeah, sir, we could.
Okay. Right.
Good morning, Utkarsh.
Morning.
Yeah. How are you?
I'm
After
good. How
long
are you?
time. Yeah. Thank you, Utakarsh. I'll just make an introduction to our students. So that will be better. So I think we met 10, 12 years before, I think, with Dr. Parag.
Uh-huh.
And it was a pleasure that you are submitting this frailty in elder care, which is needed in for our students. So, for the students, I will be giving the glimpses why I've called Dr. Krish Malge sir to request to present this particular topic. Recently, he has presented on 101st American Congress Rehabilitation Medicine Conference, and it was like a wonderful presentation given by a lot of feedback given by the participants, and it was a great presenting ability, and he's given us a lot of contribution to occupational therapy, even for US as well as India. So most of the time, he's trying to contribute for our Indian occupational therapy population as well in occupational therapy update. So I will try to invite Dr. Chris Malge sir to take the presentation for our students. Thank you very much, sir.
Thank you, sir. Thank you for that good introduction.
Yes. You
Was
can start.
was yeah, we'll start with the presentation. Frailty and occupational therapy, enhancing quality of life in elderly. So, each occupational therapist have their own definition for what occupational therapy means, or what that word occupation in occupational therapy means. My personal perspective about occupational therapy or that occupation is like, any activity or any task, anything that an individual or your client likes to do, wants to do, or needs to do. So it is any activity like, a 5-year-old child with, developmental delay is having some writing issues. So, that activity of writing just for that 5-year-old child, that becomes like his occupation. Whereas, like, if you see a 25-year-old person, he met with a motor vehicle accident and he has a wrist injury. Dressing is going to be difficult when you have a wrist injury. So that dressing, that activity, that is like an occupation. Whereas an occupational therapist works with that activity to make him independent. Now I'll give you example for like, a 65-year-old person with dementia. For that dementia patient, just playing simple cards, that becomes that activity, that is his occupation. So that occupation is like any activity that a person likes to do, wants to do, or needs to do. And how that, that simple activity can improve his quality of life. And as an occupational therapist, we work with them like, increasing their independence with that specific task or that specific activity using like, rehabilitation model or any compensatory techniques or any adaptive equipments. So that's what that word occupation and occupational therapy means to me. So now what are the different occupations in every individual's life? Humans are occupational beings. Every individual, throughout the day performs like 20 to 30 different activities. Like I said before, occupation is any activity or any task. So like if you see, for example, sleep itself is one of the activity that every individual performs. Like you get up in the morning and then you walk to the bathroom, like that is called as a functional mobility. That is another activity. Then dressing, bathing, grooming, all these activities, these are called activities of daily living with that individual. You see how many activities an individual performs in a day. That is just a beginning. Then after dressing and everything, the person gets ready to go to work, just walking to this driveway or just getting into the car or like driving to the work, community mobility, all these activities, all these tasks, these are considered as occupations. And we as an occupational therapist ensures that our client is independent with all these tasks. So that's what that word occupation in occupational therapy means. And these occupations in individual's life or these tasks, these are not like something pre-programmed. This is like daily activities, daily tasks, and every individual completes it. So those are the occupations. Now let's talk a little bit about frailty. But before going to the frailty, all the students, everyone attending, everybody has their own definition for occupational therapy or occupation. So I want you to write these questions and just write it on a piece of paper what that occupational therapy means to you. Because everywhere you go, like when you go into the practice, every person has been asked this question at least 10 times or even more. What is the difference between occupational therapy or physical therapy? So what is your own definition of occupational therapy and what that occupation means to you? So I just give a 1 minute for all the students to just write what occupational therapy means to them. It can be a simple thing. It doesn't has to be like, a definition from Pedretti or anything. Your own words. So I give you 1 minute to write your own definition. And you can just keep that as for yourself. So that in that case, like whenever somebody asks you what is occupational therapy, or usually you get question like, what is the difference between occupational therapy and physical therapy? So you know what that occupation or that occupational therapy means now. Let's get on to the frailty now. So what is frailty? Frailty is a condition that is resulting from increased vulnerability to stresses due to decline in multiple physiological system. Different system like musculoskeletal system, cardiovascular, or even respiratory system, when the functioning is not at max potential, when their functioning declines due to some medical conditions or even other reasons, that's when your ability to perform any activity or any task, it goes down. Again, I said any activity or any task, that means their occupation. The individual with frailty, his ability to perform the task goes down. Then it can be the simple task like dressing, or it can be just a simple writing. So all those abilities are impacted, all those occupations or those tasks are impacted due to frailty. Frailty is commonly seen, in elderly patients, like over 65 years old. You see like 10 to 20% of people affected due to frailty. And it's very common that's, weakness, the common symptom for frailty, weakness. You see it in all the individuals, like almost like post 75 to 80. You're going to see some kind of frailty in those patients. So what is the importance frailty and how it is significant to occupational therapy? Like I just said, like, with frailty, it affects the daily living activities. So as an occupational therapist, we use different rehabilitative strategies or rehabilitation model, adaptive equipments, or compensatory strategies in order to overcome that frailty and enhance the quality of life of that individual. Occupational therapists can intervene early and help to maintain function and decrease their dependency, just improving their ability to perform that task or that activity as simple as dressing, or just like any other task, just driving, person's driving ability. How as an occupational therapist you can improve his life by maintaining that his ability to function, by maintaining or improving his that ability to perform that task, is the role of occupational therapist with frailty. So what are the different indicators? So how do you know that the person has frailty, or how do you know that the person is frail? Any weight loss, anything more than like 10 pounds, which is equal to like 4 or 5 kilograms in the past 1 year. Somebody with a weight loss, or weakness, hand weakness, or overall generalized weakness, lower extremity weakness. Person feeling like fatigue or exhaustion, like, exhausted with just a minute activity or a smaller activity, just walking to the bathroom, or just, standing and doing simple tasks. A person feels exhausted, shortness of breath. So these are like, key indicators for frailty. The walking speed, your walking speed is declined with frailty. Any physical activity, even just a minor physical activity, it impacts the individual's ability to perform that task. That's what, like, those are the few key indicators for the frailty. Weight loss, weakness, like decreased balance, or inability to walk, or when their walking speed is declined, or any low physical activity, which results in, like, shortness of breath or exhaustion for that person. So when you see those few symptoms, that's when you can see, like, the person is frail or is at risk for fall. So when you see those key indicators, you should be, as an occupational therapist, you should be knowing, like, now this is the time, like, when you can intervene and work with that client. So I have a simple little bit case study, a 76-year-old John, he was worried for not being able to do things like just simple as making coffee. Like I again said, like any activity, a simple task. It can be a simple activity, simple task. He was able to do at one point, and now he's not able to do it because he passed the age around 75 or 65, whatever it is, and then he's like having frailty. So that's what is impacting his ability to perform even a simplest task, like just simple making coffee or making tea. So what it takes to make a coffee or make a tea: standing balance. You see, like, weakness, like I said before, weakness is one of the common key indicator for frailty. Second one was balance. Like, when the John working with the John, his balance was not that great. His balance was poor, so which affected his ability to perform that simple task. Cognition, even just for simple making coffee, there is, like, sequencing of the task. First, whether to add milk, whether to add water, or how to start the gas stove. Those things are impacted due to the cognition. Like when the cognition is affected, a person is not able to perform all these tasks. So those were, like, physical aspect associated with making coffee, or cognitive aspect. Some social aspect, John used to drink coffee at one point with his, like, grandkids and kids. Now because he's not able to do that, or even his community mobility is affected, he's not able to drive, so he's not able to go out and have coffee with his friends. So you see how just a simple coffee activity, or just drinking coffee, which is affected due to frailty, and how it affected his social life. So just a simple, all the activities or all those tasks, those are associated with, like, physical component, associated with cognitive component, associated with social component. And when all those things are affected, it ultimately leads to some mental disorders in the client due to social isolation, like anxiety, depression. Those are the things which can lead to different issues in the person's life. So you see how just a simple activity of making coffee, which was associated with physical component, cognitive component, and social component, which affected John's overall life. So as an occupational therapist, you will try to work on those areas and improve his quality of life. So what are the implications for occupational therapies? As an occupational therapist, first we identify the areas of impairment, and then just write down the client-centered interventions, or target the client-centered interventions. Like we discussed just a little bit ago, how the cognitive deficits affected, like with just simple task of making coffee. Functional mobility is affected, the community mobility, lab physical deficits, social deficits. Making coffee itself is another instrumental activity of daily living. And then when all these functions are affected, when all these areas are affected in individual's life, it leads to social isolation, isolating themselves from the external environment, which affects their overall mental health. That's when you see, like, isolation, then anxiety, stress, depression, all those psychological factors come into play. Physical impact due to frailty. Physical impact. Every person, a frail person, he has always a fear of fall. He, every person like after 65 has fallen at least once or twice in last 1 year. The falls can result into fractures, and this physical impact is due to some loss of muscle mass, sarcopenia. It also affects their ability to perform their activities of daily living, like we talked about: dressing, bathing, grooming, hygiene. All those areas of ADLs are affected. It also leads to the psychological impact: fear of falling, anxiety, social withdrawal, some cognitive decline, and depression. Social impact: dependency on caregivers. When a person is frail and at the end stage, the person is going to be mostly like a bedridden. That's when like dependency or caregivers, or even like a simple activity like going outside or going to the marketplace or bringing their grocery or something just simple as milk. A person is dependent on some caregiver or family member, which like you see reduced participation into their any activity, meaningful activities, or whatever activities or tasks they perform. The social impact. Then cognitive impact, sequencing of any task. Like just for making coffee, we talked about sequencing. It starts with like putting on the gas stove. The person is not able to know like what to start with, how to end the task, termination of the task, issues with problem solving. He doesn't know like which one to start with, like which one to put in, like whether to put in sugar, whether to put in salt, or put in coffee pot, or whatever it is. So that's how like cognitive impact affects just a simple task, even a simple activity. Person's functional mobility is impacted. ADLs, IADLs are impacted. So what are the OT's responsibilities? Key OT responsibilities. As an OTist, we'll first do the functional assessment, identify the physical and cognitive challenges in the patient. Physical challenges, especially like you see, their coordination is impacted, fine motor coordination, gross motor coordination, strength, hand and upper extremity strength, then the balance, static balance, dynamic balance, or even the crossing midline, or reaching up in the cabinet, or just lateral side reaching, forward reaching. So basically the reach is also affected. Client-centered care, whenever you set up the goals, those goals should be meaningful to that client, and the goals should be achievable. You cannot like when the patient or a client with a frailty, he's kind of at the end stage in the bedridden, and in that cases, if you see a patient like if you set up a goal for like patient will walk to his bathroom independently, which is kind of unachievable goal, because the patient is bedridden and like unable to move out of bed. So just an achievable goal for that patient would be some bed mobility or even just sitting tasks. So goals always designed should be meaningful and achievable. And the core goals are just to increase their independence, enhance their participation in ADLs and IADLs, and prevent any secondary complications, just like falls. Okay. So what are the tests to assess? Frailty index. Frailty index is one of the tests, where 70 to 75 of different areas, a patient mark them what areas are affected with him. And it actually assesses only 6 areas: cognition, physical strength, then it also affects social impact, the client's activities in society or in community. It also assesses his toileting abilities, ADLs, and cognitive abilities. I'm just explaining all these tests in just giving you overview. I won't be explaining in detail. Like, the second test would be like functional reach test. So what is functional reach test? A client reaching forward, A normal functional reach is 3.5 inches for a client. Any client having functional forward reach less than 3.5 inches is considered as like high fall risk, and that for the patients for about 65 years of age. Then the next test is the grip strength. Grip strength, with the dynamometer. Take like 3 measurements, then an average of those 3 measurements. Grip strength, because the grip strength, or if a person doesn't have that enough grip or power in his hand, he's not able to hold any items. And that's when coordination is affected, or coordination is seen like, just eye-hand coordination, or simple like fine motor coordination is affected. They don't have that much strength in their hands to hold on to the little bit heavier items. So next test is tug test, time up and go test. The person is sitting on a chair, unsupported. He stands up by himself, walks around 10 feet, which is almost equivalent to walking from his bed to the bathroom. Kind of that much walk. The person turns around, comes back, and sits into his chair. So these are the 4 tests, you can use for frailty. So till now, we saw what is frailty, what are the occupational deficits related to frailty, and what tests can you perform to assess the frailty. Now, different OT assessments: physical functions, cognitive functions, psychological impact. Home assessment. Home assessment is something like, you can start the time you enter, you see the patient's home. Like just when you enter the patient's home, see like, where they have side rails. Do they have any steps? And are the side rails on the right side or left side? Because at times you'll have like patient who has knee injury, like total knee replacement. So whether it's right or left. So in those cases, you have to see whether the side rails are on the right side or left side. Then simple ADLs and IADLs. Now, OT goals for frailty: promoting independence with functional tasks, all their ADLs and IADLs. Safety with performing functional tasks. Safety is one of the key issues working with patients. Safety is always priority, because the frail patients, they are high risk for falling. When a person falls, it leads to fracture, and then again hospitalization and rehospitalization. And whenever a person goes to hospital, their ability to perform any simple task, 1 day of hospitalization is equivalent to 6 to 7 days of rehabilitation. So you see how safety is very important with our patients. Reducing fall risk, improving their physical and mental health. And the last point, overall enhancing quality of life and living in the community with respect and dignity. That is the most important aspect we work as an occupational therapist with our client, enhancing the quality of life and living in the community, making sure that they are safe in the community. Now the intervention plan, just having an overview of what exercise plan or what would be the client's future intervention plan would be, just like home modification. I explained a little bit about home modification, like, when you enter a client's house, just knowing the bed rails, or even adding a grab bars into the bathroom, or looking into their lighting, how much light they have. Like elderly patients, they have all visual deficits. So those visual deficits, making sure they have adequate lighting in the house. Second one is exercises. Introduce some strength and balance exercises. Education on energy conservation techniques, improving their physical and mental health. Now, OT intervention. So exercise programs. So what exercises can we give to this frail patient? Strengthening exercises, simple basic strengthening exercises for these frail patients. They are already like 65 to 70 years old. So in those cases, you don't need to give them heavy weights, just a simple 1 pound weight, 2 pound weight, or at the max 3 pound weight. Simple weight and simple exercises to improve their hand strength, to improve the grip strength. You have to give the gripper resistance band. and they're just the light weights. Those are just enough, just right amount of weight for that patient, depending on their need. Then some balance exercises, static standing balance exercises, dynamic standing balance exercises, Tai Chi, and all these balance exercises. Balance is very important with these clients because when a person is having poor to fair minus balance, his chances of falling are always high. So a person needs to have like fair or fair plus in order to perform any standing dynamic activity. So ensuring that their balance is at least fair, and especially with elderly patients, their chances of falling are always high. So that was like exercise program. Now all these patients at some point are going to need some assistive devices. So recommending them the assistive device that they need. Some patient might need a walker. Some patient might need a canes. It can be just a two-wheel walker, or it can be like a four-wheel walker. So depending on the patient's balance and depending on the stability, as an OT, you can recommend them different assistive devices. And then again, after recommending that device, training them for proper device use. Some environmental modification for these clients, checking their home, making sure that, like, there are no loose cords. Nowadays, you have computer cords or phone cords, just making sure that like they don't have any loose or hanging cords. And just like, whenever you do a home assessment, yeah, you need to check whether the patient is able to get in and out of the chair that he sits in mostly, or even just a simple bed mobility. Is the patient able to get in and out of the bed? Can the patient walk to his bathroom? Can the patient walk to his kitchen? Is the patient able to just walk outdoor a little bit? Ensuring that there are no carpets or throw rugs in the house. So those are a few of the home assessment things you can check. Then adaptations such as grab bars or raised toilet seat. Does the patient needs any other adaptations in the house? Does he needs, like, how much he can walk? Assessing again using that tug test. Is he able to walk? Making sure that, like, walking to the bathroom, is that something he's able to do? Or does he need any other adaptations? Psychosocial interventions, addressing the isolation through group activities or telehealth, and some support strategies for anxiety and depression. Isolation is something like, you see very common in this patient. So just ensuring that like they are into some kind of groups and having those group activities, or even ensuring like, they are still in touch with the family or having some connection with, outside friends or even the group. So just to reduce that isolation from the society or from the community, and using some support strategies. Nowadays we have a lot of those different apps also which works for the anxiety and depression kind of things, so that just the people keep themselves busy and not just being feeling fear of isolation or being abandoned from the society. Education and preventions. As a therapist, you can always educate your clients and families on different lifestyle medication, lifestyle medication like nutrition, proper diet, physical activity. Educate them on the importance of physical exercises or simple physical activity. For this client, the simple physical activity would be just walk in a garden or just walk outside a little bit, or even a simple exercises with 1 pound. And you can always give them a home exercise program, simple home exercise program designed like, with 2 pound weight, or even the TheraBand activities, just simply showing those figures or just putting those figures on a piece of paper and just giving them that piece of paper, during the discharge. That is very helpful because with frailty, the patient is bound to get better, but the thing is that after a month or after 6 months, the person is again going to feel weak, or he might have some symptoms related to frailty. He might have few issues related to frailty. So that home exercise program, just assessing or following up on whether the patient is following his home exercise program, or does he feel like he has fear of falling or any other issues related to it. Overall, improving their functional task training, ADLs and IDLs, kind of very important thing for an OTs, looking into their what activities of daily living things are impacted, or instrumental activities, any other activities are impacted with them. Basically, only one main goal with all these clients is like enhancing their quality of life, improving their life, and bringing them back to the community, ensuring that they live with respect and dignity. Now, as far as OT is concerned, as an OT, we give a lot of different activities and exercises, adaptive equipments, following the rehabilitation model, and even giving them some compensatory techniques. But is that going to be enough for that patient? No. So, like a physical therapist, so what as a physical therapist role is with frail patient, working with the lower extremity. Because when you work with in the US, you can only work with upper extremity. That's the biggest difference between OT and PT in US. OTs can work only with the upper extremities, and PTs can work with the lower extremities, basically on the strengthening. When it comes to strengthening, OTs are not allowed to do muscle testing or any kind of strength testing for lower extremities, and same thing for upper extremities with PT. So working with an interdisciplinary team, this frailty is not just a one person thing, not an OT's job, but it is an interdisciplinary approach to frailty. Nutritionist, proper diet, weakness, reducing muscle mass, sarcopenia, we talked about it. So that's where nutritionists come into play. Physician work basically with the medical need, what oxygen person needs, or what other medications or any other medical illness. And we talked about caregiver, like at the end stage, like when the person is bedbound, in those cases, caregivers. So with frailty, it's not only OT's job, but it's an interdisciplinary approach, ensuring that client stays independent for longer time. Post interventions, like after therapy and everything, patient is going to get better, but is that enough for the patient? So as an OT, you have to follow up after 1 month, after 3 months, and after 6 months, like just ensuring that he's following that home exercise program, or he's still into engaging himself in the society with different community groups, or even giving him simple cognitive games, just ensuring and following up that he's still into those programs and those community activities, just to ensure that weakness is something with exercises, patient may not feel weak, but after a month or 2 months, if a person stops, he's going to again go back to the same level. So ensuring that just to maintain their current level of functioning, you have to keep a follow-up at least for a month, just one phone call and asking them, does he feel does he has fear of falling, or is he following that home exercise program? Is he still keeping up with his society and community activities? Is he engaging himself in some cognitive games? So just that's post intervention. Now, rural areas, I like to put this point into most of the presentation, like how frailty or any other challenges in the person's life, and what are the areas like as an occupational therapist can work, what challenges or what solutions you see from occupational therapy point of view in rural areas. Like if you see, if you go 50 kilometers from big towns, like in in Tamil Nadu, Coimbatore and Chennai are the cities, like two major cities. It's kind of similar everywhere. In US also, every state has like maybe 2 or 4 big towns. But when you pass those big towns, like 50 miles from those big towns, you land up into the village area or a rural area where you don't see as much healthcare. So there are a lot of challenges people facing there, and that's where not many people know what OT is or what's the role of occupational therapist. So challenges, what are the challenges you see in the rural areas? And by that I mean it's kind of same in India and same in US. When you go 50 miles from the bigger town, you hit the rural areas where you don't find specialized professionals or even like intensive care units. So as a what as a healthcare professional or what as an OT you can do? Telehealth, telehealth for remote consultations, or just a community-based rehabilitation program. Community-based rehabilitation programs are you can just as an OT can get into the community and arrange those rehabilitation program, just a simple rehabilitation program, simple exercise program, probably once a month or once in a 2 months, or even training those local people for some exercises so that at least if they need some rehabilitation or somebody else in the community is needing rehabilitation where there is very scarcity of rehab professionals, that's where those healthcare workers whom you train them as a doing some kind of exercises or some kind of adaptations or some kind of compensatory techniques. So that's when you can do in for the rural areas, and in that way you are even creating awareness in those rural areas, partnering with local organizations, churches, community places, or community centers, or even the temples, where you can, as an OT professional, you can work once in a 6 months, just one visit for 3 hours. It not only creates awareness, but in the society, even in the rural areas, it improves and it increases the knowledge and awareness about OT, and plus people get those services they need. So that's very important, from the rural aspect or the village aspect of how creating awareness kind of thing in rural areas. Now I have a little case study based on this, what assessments you can do with frail patient, what interventions you can do. So a client is a 72-year-old female. She lives in a rural area. So just the frailty indicators. What would be the frailty indicators with her? It would be weakness, exhaustion, fatigue, and probably some history of fall. So what are the OT evaluation areas now? Different OT tests you can use. We talked about tug test, functional independence measure test, or even the work balance test. Looking into the goals, improving their mobility or reducing their fall risk, enhancing safety at home, doing home assessment, and recommending those home adaptive equipments or some of those home modifications. What are the outcomes of this client? Confidence, improved confidence, reduced in falls, and independent with ADLs and IDLs. So conclusion with this case study and everything, what are your key takeaways from today's this simple frailty and occupational therapy? It tells early intervention is essential. As much as delayed happens, the frailty, it reaches to a point, it reaches to an end stage. The early intervention is very essential in order to ensure that your client is able to maintain that balance or to hold on to that balance or that strength or his ability to perform that task. So early intervention is very essential in frailty cases. As an autist, you can be advocate for community, advocate in the community, especially in the rural areas, providing them the different resources. So that's pretty much about the conclusion. And I think here we have all these things. Occupational therapy, inspirational quote, occupational therapy transforms lives by focusing on the ability and not the disability. So as an occupational therapist, you focus on their abilities and not the disability, enhancing their quality of life, transforming their life by giving them different, adaptive equipment or whatever whatever the need is, depending on the client situation or the client current condition, focusing on their abilities and not on the disabilities. Key findings, exercise program that was led by OT significantly reduced frailty in older adults. This was a study in 2013. And some home modifications that reduced the fall risk by 39%. And this study was in 2014. And psychological support, it overall improves the mental health and outcomes and participation in the activities, which was seen in the same study. And like I talked a little bit about nutrition and physical activity, physical therapist role, and physician's role. Same thing like lifestyle medication in frailty, like emphasizing that aspect, nutritional aspect, activity, physical activity, or even the psychologist or social worker working on the stress management techniques. And here are some references. And any questions? Like we talked about so much about frailty. Now, do you have any questions?
Yeah, sir, thank you. I think the people can ask their queries by typing the message over it in your message sections. If anybody having queries, kindly type it as text.
I think Dr. Utakarsh, it was a wonderful presentation for our students as well as for the OT community. I have shared it with other Delhi forum as well as for the Goa forum. And most of them are in YouTube live as well. So nobody has raised a lot of questions. They have understood real picture of frailty in elder care through our occupational therapy perspective. And it was a wonderful experience. As you are still in US, can you able to share a little bit about the US way of protocols, or the because how they are giving importance for the aging, rather than in India, it was not considered as a disability, because most of the time we neglect the elderly people because it was being taken care by our own family members and the caregivers. But in US, everybody wants to be very much independent on their own, and still the geriatric care is very much popular. So can you able to give a little bit of glimpses about it?
Yes, like you see in the US, like skilled nursing or long-term community care is where like you will see mostly like all the elderly patients, and you don't see it as much. But as far as now, I see some of the areas, like especially metro cities, they're having some of long-term community care. They're having some aging in place and those things, but not many. And here, like everyone, like people, or even the elderly patient, they want to do everything by themselves. They want to do, like, they want to be independent, whether it be driving. Even I've seen even like 90-year-old person driving, but you don't see as much like even people living up to 90. I'll give you my personal example. My mom, she's 75. She's not able to walk more than 100 feet. She can just walk one hallway. You give it to your patients, you see how the difference is. But here the person wants to be independent. So that was one big difference I have seen. Like people are a lot adamant about all those different changes. Like here, doing home modification is one of the basic things from the OT perspective with these elderly people. But I see from my personal aspect, like I told my mom, like there are some things that we need to change in the house because you're gonna fall. You're at high risk of fall. No, no, no.
Yes.
This is the house I lived in for last 50 years. I don't want it to be changed, anything in it. I'll live here. I'm gonna be here. There's no changes. So like that is one, one I see, like mindset, like in elderly people. They don't want any changes, but here the people want, like they want to be independent. They don't want to be dependent on anybody else. So even like 90-year-old person driving around a car, it's perfectly fine here. But you don't see as much. And like from OT perspective, biggest thing is like home assessment, physical activity, exercise, and even like here, like long-term community care, they have their own dietitian. So following that nutrition. And one major thing I've seen, like the age this thing, aging is also a lot earlier in India than here. But there are a lot of environmental factors also. Not only those factors, but like environmental changes and everything. Big difference.
Dr.
Is it?
Utkarsh, I think from our lecturers and as well as our faculties, they have Mrs. Gayatri has asked a question like, what is our major role in fall prevention? I hope I think we will be giving a separate topic on that, but still you can touch some of the glimpses. One of our even assistant professor Gokul Raja sir has asked about the visual support techniques to useful for persons with low vision during the elderly time, because most of them will have some kind of due to diabetes or any other reasons they will be have a low vision. So how to prevent it? Even though I have attended the low vision training in Manipal for the low vision people, but still, if we can able to test those glimpses for them, it will be more useful for us.
Yes, we'll start with the fall risk. Fall risk, first thing, like, with the elderly people, anybody above 65, they've at least fallen one or two times in past 1 year. And some falls, they are fatal. Some falls results in the fractures. And once a patient goes to the hospital, 1 day of hospitalization is said to be equivalent to 6 days of rehabilitation. So if a person is at the hospital, if you see in that way, like, stays in the hospital for 5 days, so it's at least 1 week, 1 month of rehabilitation for them. So fall is the biggest thing we see over here for hospitalization or rehospitalization. So just preventing those falls, like I give little bit information on home modification or home assessment. Uh, Even giving those the simple basic idea, like arranging the furniture is one other thing. Making sure that the carpet is not loose in the house. Nowadays we also have a lot of carpet in India. So making sure that edges are trimmed, or like even giving them the assistive devices, whether they need walker, if they need walker. But some people won't like to use those things, so that's different thing. But just basic, environmental modification is one major thing when it comes to like fall risk. I gave example of those railings. When you enter, do they have steps to enter the house, and whether the railing should be on the right side, whether the railing should be on the left side. Modification in the bathroom, like grab bars or their toilet seat, what height toilet seat they need, or do they need grab bars, or even just like kitchen modification in the house, where should be their utensils, at the kitchen countertop level, at the kitchen table level, so that in that way they don't have to bend too much to reach down, or they don't have to, making sure that they don't have to reach up as high as they can. So, and for fall, I mentioned few tests like tug test, and there are also forward reach scale test, and time up and go test, and sit to stand test. They're like those 3 4 tests, very good for fall, assessing that fall risk. And
But here, most of the time, they use BBS, Dr. Utkarsh, Berg Balance Scale.
yeah, yeah, that is another common skill, but these are like simple basic skills. You don't need a lot of those things. But like tuck test, the person has to just stand and walk for 10 feet, just knowing is he able to walk to the bathroom. Sit to stand test, is he able to stand up like 5 times, 6 times? How many times he can stand in just 15 seconds?
We will
I
actually,
personally,
one
I
of
personally use
our,
I personally use a lot of those scales. Work balance scale, I'll use only at the time of discharge.
yes,
Because evaluation, for evaluation we get 45 minutes, and in 45 minutes, work balance test is itself going to take like 15 to 20 minutes at least.
yes, that's a practical issue in US
Yeah,
as
and
we work for
even
the
like
India.
at the time of evaluation, patient is not at that level to do even initiate the work balance. But yes,
Yes.
at the time of discharge, it's fine.
One of our even the lecturer asked questions like how can the cost effective adaptations be made in rural areas of India. I know that actually you worked previously in India, then moved to US, so it will be a little difficult because how they are combining with the government and doing over here. But one more issue is like home modification for those people, because here we don't have much assisted living centers. Nowadays, it is coming up in some of the cities like Coimbatore and even in Chennai and many other places in Mumbai as well. But how we can able to do a home modification? Did any protocols like with the US? Like for example, I worked in Singapore where they have a HDB people like housing development program. So they will be doing the modification. Even the design will be given by assessments and everything is done by the occupational therapist. But here in US it's different, and in India it is different.
Yeah, in US also it is same. Like, as an OT, we can recommend that the patient needs a grab bar, or patient needs a side railings, or the patient needs any other adaptive equipment, the toilet riser, or the patient needs like, walk-in shower. Then you have to take the tub. But it's all like we recommend it to those specialized people. All we can give is just the recommendations. And whereas the simple adaptive equipment, just like the reacher or any other grab bars or those things, like, we can actually have them just buy those things.
As it is like we also have some kind of a stigma like using the specs or even the having the grab handles, and everything is like it is an icon as an old age, and most of the people doesn't want to show their old age because we do dying, we do many other things to hide our aging process. And
Exactly. That's
yeah,
why I gave the personal example. My mom, like, she doesn't want to use the walker. She's like, I don't need it. You just give it to your patients. I don't need any changes in my house. It's been that way and I like it that way.
still hopefully we will try to include those updates and trends in frailty care. This will be a glimpses like our newest batch as well as our batches will be able to explore in their community and when they do practice. Thank you very much, Dr. Utkarsh. You have given your time and enriched of knowledge in our geriatric care and the protocols which followed in our US as well as in India. So thank you very much. We'll be in touch with you, and we will be
Oh,
giving more more contribution to our students as well. Even in the later time, I will be
yes.
connecting with you, and
Yeah, yeah, sure.
we always be thankful for providing
Yeah.
this time for us. Thank you
Yeah.
very
No,
much.
thank you
And
so much for having me. Yeah.
yeah, Dr. Dani ma'am, please you can give your thanks.
Sure, sir. Yeah, I think it's a very good, nice sessions with you, with like sharing your experience, and you had given really a great insight in a field of occupational therapy where we least give importance in India. Like the it is like something we are uninvaded area of practice in terms of OT within our India, which is yet to be grown in the future. So I think students and all our participants have a very good understanding and the need of the hour where everyone be it is being changing now. The view over the future is being changing, and hopefully we expect our new young generations to cope and invade well with the areas. And it was really an insight sessions for all of us to explore and how it can be the benefit to the people of elderly with their occupational loss, and how an occupational therapist can guide them in all the areas of perspectives. So it was very good sessions. And as a part of a webinar, this is a International Day of People with Disabilities. I like to thank upon on behalf of our institutions and on behalf of our managements to spend your valuable time. Along with that, I thank our management trustee and chairman sir and chairman ma'am and directors and dean ma'am to give us the permissions to open fully to conduct this webinar as a very successful one. And I also thanked our principal sir who always been explored to the new topics which has been not much been invaded in OT, and that been a higher perspective that we are always looking forward to it in untouching the areas which is not invaded. And we are successful enough in bringing out this webinar as a event, and I think many of the questions been answered very politely. And thank you so much. And we are always being open to interact with you in the upcoming futures also with most of your experiences and seminars. Yes, sir. Thank you so much.
Thank you so much.
Yes.
Thank you, Dr. Utakarsh. Thank you
Yeah.
very much.
Yeah. Thank you. I was glad to be here. Yeah.
Yeah, sir. Thank you so much.
Thank you.